we are heading to our next panel talk, which is on remote patient monitoring and telehealth. And we have a very, very great panel to discuss amazing topics, which will be in the continuation of the recent panel talk that we just had. I would like to call upon Dr. Sara Khurram, CEO, Sehat Kahani. Guys, please appreciate. Anyway. Next we have Dr. Suhail Chughtai, CEO, Citrus AI. Guys, please, hand of applause. These are the great leaders and mentors to us. Dr. Fariha, consultant cardiologist, Tabba Heart. Yes, yes. Then we have Mr. Naveed Alam, senior engineering manager, Medtronic. Mr. Noaman Zaheer, GM Admin Popular International and a robotic expert. Mr. Noaman Zaheer. Please. Great, thank you. So, Dr. Sara, I would like to start from you. Okay, great. So Pakistan, as you know, we have over 220 million population, and but still the doctor-to-patient ratio is very low, approximately one doctor for every 1,300 patients. And the platform like yours, like Sehat Kahani, you are doing a great job from past many years delivering healthcare through telehealth services in the underserved areas. So what are the most biggest challenges for you to penetrate digital health across Pakistan?
That's a huge one. But thank you very much. I'm so happy to be here. I think the first session was so enlightening. Lots of my teachers, mentors were present, so it's a super experience. Thank you to Dr. Zaki and his entire team for pulling this together. Yes, I think there is a huge doctor-patient mismatch in the country. Pakistan may less than half a doctor have 1,000 patients, or one doctor for 1,300, 400 patients. And as I think Sir also mentioned, there is absolutely no way you can fulfill that gap by creating more doctors, because there will never be enough doctors for the population that we have. एक बहुत बड़ी चीज़ जो हम मिस करते हैं इस पूरे सिनेरियो में वो ये कि 85% of Pakistani doctors work in the urban areas, when majority of your country is rural. So there is a huge rural-urban mismatch of doctors as well. And of course, इसमें एक huge disproportion of female doctors है जो काम नहीं करती. I think building Sehat Kahani, which is a digital health platform that connects doctors to patients online using quality and affordable healthcare. If you don't have a smartphone, you can visit one of our e-clinics in a low-income area and get consultations via an online doctor. If you have a smartphone, you can use our app and get connected to a doctor, and it goes on and go forward to having access to pharmacy, lab services, health education and promotion. I think the biggest challenges that I've seen building Sehat Kahani is, I think, more internal as well as external. Right now, as a growth stage company or a growth stage organization that has transcended through 8 years of operation, I think my biggest challenge is there aren't enough opportunities available for younger stage companies to grow in Pakistan, unfortunately. We see a lot of organizations coming in and working. Creating smaller pilots, you will go around the halls today and you will see a lot of smaller innovations and smaller companies budding out and creating new things, creating AI-enabled technologies, creating digital health platforms. But in actuality, to grow an organization and to scale it to a level that Pakistan is, which is 250 million people, you do require resources which are humongous. And those resources, unfortunately, in the form of funding, is not available in the country, and that does create a problem for organizations like us and many others to grow. I think the second thing, if you're creating any digital health solution, any AI-enabled solution, anything related to technology, and I don't want to sound redundant, but unfortunately, internet penetration and good internet penetration in Pakistan is still a huge problem. Even since the last week, we're sitting in the biggest metropolitan city of the country, and my internet is not working. It's not working on data, it's not working on Wi-Fi, so how can I blame someone in a low-income area to access my service? Lack of appropriate infrastructure, be it internet technology, be it data interoperability between different platforms and hospitals, does remain a huge issue. Third, I think, is the digital health solution has to provide a better experience as compared to what they are getting before. I think that is something that we all need to work on. What I see is there are a lot of companies who've come up, there are a lot of organizations who are creating that digital solution, but are we actually measuring the quality of it? Are we actually making sure that if patient comes to us as a digital health platform, the quality of care that we are providing to them is better as compared to a physical doctor? If it is not, patient will never come to us. And that, I think, is the biggest challenge. I wish we had the people in the front seat sitting and we could have told them and I could have said it in front of them. But my biggest challenge, and I'll end here, is the lack of appropriate regulation and standardization in a country like Pakistan that has a huge population and a huge, huge opportunity for digital healthcare. But till date, we do not have a federal level digital health policy to govern any platform that is working. So if I am using Zoom, you're using WhatsApp, anyone is using any platform to provide consultations, it doesn't make a difference. We are ISO 27001 certified, that takes an year to complete. I know a doctor group that runs on Facebook that shares patient records like candies to each other with data of patients floating around and providing consultations on Facebook. So unless we can regulate, we can standardize, we can have minimum standards available, unfortunately we will never give the experience to the patient on a digital health platform better than a physical platform, and people will keep turning back to the unavailable, low in numbers physical doctors or quacks or dispensers or midwives rather than coming to us because we are not giving the quality that we are promising. So I think that is my biggest, hugest challenge, that we need to create regulation, policy, and standardization for healthcare companies who are working in the digital or the AI sector.
Thank you so much, Dr. Sara. In fact, I believe the issue that you have raised related to compliances, it is so crucial that I think one day, if compliances doesn't become a point of concern for governments, then one day quacks and other non-medical professionals, they will take advantage of digital health platform and it will become a marketing tool for them.
Can I give you one example? So we create telemedicine clinics in low-income areas and we place doctors, virtual doctors with nurses. So you walk into a clinic, there's a nurse, she connects to a doctor and you get a consultation. We've just faced a challenge 6 months ago in one of our clinics in rural Punjab. Opposite to our clinic, there's a quack who launched his own telemedicine clinic and he was connecting to another quack. So he was sitting and he said, I'll connect you to a very good doctor in Islamabad, and that doctor was another quack sitting 2 feet away wearing a lab coat.
Yeah. And by the way, Pakistan have more number of quacks than original doctors.
And this is what happens when there is no regulation and overshadowing. So this is just one teeny example of the bigger problem that we are handling.
Agreed, 100%. Dr. Suhail, my question is from you, that AI-powered RPM is something that global world is working on, and it is solving global digital health-related problems for the world. But what's stopping Pakistan to adopt AI-driven solution and AI-driven RPM, and why hospitals are so low in terms of adoption rate of such solutions?
So thank you, Bilal. RPM is remote patient monitoring. Yeah. It's a virtual hospital system where you admit the patient at home. You don't bring the patient to hospital. Now, the qualified to do RPM, just want to give you just a few seconds of background of RPM. You have to have a chronic medical condition that is monitorable from distance without any acute threat. That's the definition of RPM. You can't put a patient on RPM which needs ambu bag or BG monitoring, blood gas monitoring. So let's qualify what comes in RPM. Non-acute patient where the chronic condition has been stabilized by outpatient or hospital, and then the patient goes in field and then we monitor that. Now, the challenges in Pakistan, first of all, poor selection of cases. You put somebody with acute diabetes, those in hospital, and go home and monitor that. First of all, we have to stabilize the patient to a way that the patient is manageable at home from distance. Then the second problem is inappropriate dashboards. Like, RPM needs 3 things. It needs a probe, it needs a dashboard, it needs a person sitting on the dashboard understanding the triggers. So what are triggers? Triggers can be of 3 levels. You can have a minor trigger, blood pressure thoda upar gaya hai, nurse just calls the patient, don't miss the beta blockers. Thoda aur upar gaya hai, it went up further. Doctor calls the patient, are you okay? Are you having any palpitation? No. The 3rd level is, it's gone shot up to 170. The specialist says, I want to see you now. Either I'm sending the nurse or you come to my clinic. 4th thing, I deployed that in Dubai and Saudi Arabia. Ambulance gets home straight away. So these things have to be understood first in Pakistan, that how to do RPM. RPM is not putting a pulse oximeter and monitoring the results on WhatsApp. That's not RPM. I'll give you one more example. You know, head injury, rising blood pressure, slowing heart rate, dilating pupil, slowing pulse rate, dropping blood gases. These are 5 indicators. Now, artificial intelligence can find the relationship between these 5 and pick up the problem early. Individually, blood pressure drops, blood pressure rises, heart rate goes down, you say head injury is getting worse. But what about the relationship of all 5? That is where artificial intelligence wrapping over the RPM will make immense diagnostic value. So I suggest that we should understand what is RPM first. What is the value? The value is very simple. In NHS, my waiting time as a consultant orthopedic surgeon in NHS is 9 months for total knee replacement. Patient I see today, I will operate 9 months down the line. Okay? Now, if I see a patient with chronic arthritis, I send the patient home after admission. But what happens after? Patient never comes back to me. So I can monitor the patient after stabilizing acute arthritis. By stabilizing and sending home, I can clear the hospital bed. That is what we should do here. We have shorter beds. We should manage patients, pick 20 conditions, and manage them at home and hospital. You will have so many beds in hospital. Thank you.
Thank you so much, Dr. Suhail. Very well said. Dear audience, we are privileged to have Professor Dr. Tahir Saghir, Executive Director, NICVD. I would like to welcome him on the stage. Dr. Tahir Saghir. Yeah. Hand of applause, please. Thank you so much, sir. Dr. Fariha, my next question is to you. You are the consultant cardiologist at Tabba Heart. Cardiology, I believe, is data intensive and also timing sensitive, a perfect use case for RPM. But we see that there are very few examples that hospitals are practicing or making this standard that their patients, once they went home back, they have any wearable devices that could send back data to their cardiologist and they can stay connected with their patients. So what do you think about this problem and what's stopping them to make this as a standard practice?
Thank you so very much. I'm really, really honored to be here in this prestigious group of people who are connected to AI and remote monitoring. My experience with remote monitoring and AI as a cardiovascular physician is growing. So I have started embracing, and I understand that the challenges that my colleague has mentioned here are the plays a pivotal role in determining who and where and how we get the remote monitoring, right? Understanding the challenges that we have on the healthcare, embracing this technology by the cardiovascular institutes is also a challenge, right? First of all, we need to give the confidence to the patient and to the physicians first by educating them that this technology is actually going to facilitate and improve healthcare and not overburden your workflow, right? Because the physicians and the institute may feel that they will be overburdened by the amount of data flowing in when the patient comes to the hospital. So they need to understand that there will be an integrated system that will facilitate. To give them this confidence, we need to have projects, pilot projects, and the data to be distributed to this to the people that will give them the confidence that this technology is here to help and promote healthcare and not hinder. Our patients there's a lot of inertia from the patients as well. Why? Because we as a community and as human beings have a nature of having the tactile touch. We don't feel that we will be taken care of if the doctor doesn't feel our pulse and auscultate our chest. Just remote monitoring is not enough. The inertia from the patients will also be the complexity of monitoring. The devices that we use may not be user friendly in every place, and then the huge inertia comes from the accessibility, connectivity that my colleague mentioned. We are depending everything on it, right? So the cardiovascular institutes and healthcare, they really need to have that confidence first. And who's going to give the confidence? There's so much data coming out from smaller projects that needs to be dispersed. And once we have that confidence, I'm pretty sure that the cardiovascular institutes where monitoring chronic cardiac conditions, diabetes, hypertension, arrhythmias, and heart failure, which is now becoming a pandemic, may be the right patient population to manage them from remote monitoring. So I think as physician sitting in a tertiary care hospital in a cardiovascular setup, I need that confidence. And my patient needs that confidence of the confidentiality of the data that is being transmitted. Yeah.
Thank you so much. Very well said and very greatly brief. So we have our next speaker whom I would like to invite on the stage, Mr. Asadullah Khan, Executive Director, Riphah International University. Sir, please join us on the stage. So Mr. Naveed, I have next question from you. Since you have the engineering background, and I would like to continue the debate from where Dr. Fariha have left. But there was a very important question that was popping in my mind, was that what is the role of the cost of these devices? That is it a problem for countries like Pakistan, which is slowing the adoption, that people are not able to afford those devices, healthcare organizations are not going to afford them? And if so, then how the countries like Pakistan are going to balance it?
Sure. Well, firstly, thank you for having me here. Great to be with everybody today. So before I answer that question for you, I just wanted to go back and kind of add to what Dr. Fariha has said previously. I think technology has to work with the physician, especially in healthcare, because at the end of the day, your patient still needs a physician. So one of the things, as always in my career working in medical technology, you have to work with your physician. Physician, of course, is your end customer, and then patient is being treated by the physician. So technology has to work in an environment which is needed by the patient, controlled by the physician. So going back to cardiovascular, I think what we've been trying to do over the last 1 year or so in Pakistan is to work with physicians, introducing them to technology which is available right now for cardiovascular application, for remotely monitoring them. So of course, if anybody wants to come talk to us, we'll discuss that. And now going back to cost. Cost of technology is, especially if you're looking at what kind of specificity you're looking for, or diagnostic data you're looking for, is complex. You certainly can get some trendable data, for example, even from Apple Watch or Whoop or other devices which are available to you. But now looking at more for clinical information that you're looking for, those devices are, especially the ones that we are utilizing, are FDA cleared. The cost of those are going to be more expensive. But what we are trying to do is to make sure that those devices, especially in wearable cases, are reusable. So that way in a market like Pakistan, we are not giving out a single device to a patient. Those devices are getting used, the cost is getting distributed among multiple patients. Right. So we need to figure out business models that allow us to be able to provide the service in a market that we are in. And then at the same point, try to develop things indigenously in Pakistan, so your cost of development is lower. So I think those are a couple of things that we certainly can do. But if we are, importing devices, importing technology from outside, those are going to be expensive initially. And I think as adoption increases, as the volume increases, as that becomes part of our natural care pathway at hospitals, by physicians, the prices are naturally going to drop.
Right, great. So you are saying that if demand increases, that of course then manufacturing cost will also decrease.
Actually, we don't do a lot of manufacturing here right now for some of those things, correct? So as demand increases, you're going to bring more devices in.
Right.
And those devices, especially the ones which are being utilized for diagnostics, the price may go down. And if you start manufacturing them here, of course, you're going to have a lower, bill of materials, and you can sell them cheaper.
Great. Okay, thank you so much. Mr. Noaman, so my next question is from you. We need a mic, please. Thank you so much. So it's been like 15 years since I've been working in the digital health space. One thing that I personally realized is that a lot of hospitals of different sizes, they take digital health as a small IT project rather than they see actual value that those digital health projects are delivering them. So what do you see, what mindset shift is needed here that the hospital and the other healthcare organizations see this as an investment and also see the value that it is driving for the professionals as well as for the patients?
Thank you, ladies and gentlemen, for inviting me here. Well, basically, the system, what we are now talking about, is the RPM, remote patient monitoring. That has only been discussed for the last couple of, I can say, 5-10 years. This is dedicated with the diagnosis only, but not for the therapeutic. The quality comes when the transition comes from diagnosis to therapy. There are multiple methods to diagnose. Post-COVID, there was a tremendous impact, and I can say there was a great revolutionary measures taken post-COVID-19, where clinics were put up, regardless to the quality, because this was merely a catastrophe. A consultant cannot go in a remote. There were distance placement. So there were alternative methods to diagnose visually through teleclinics, then going to the conventional lab diagnosis. The quality remains compromised when there are multiple methods for diagnosis, but it can only enhance when it comes to therapy as well, like surgeries, not through AI. Humans cannot replace robots, but robots can support, help the surgery, the surgical procedures being adopted and then adapted. First is adaptation. Second is adaptation. We are only discussing the adaptation, not the adaptation. When we adapt something, we consider all the basic and advanced parameters considering the quality, the performance, and gauging. But once we only adopt one thing, we do not adapt that. So there is a very thin line between those things. The quality will improve once we give a transition from diagnostic to therapeutic.
Okay. Yeah. So this is that mindset shift that you are saying that medical professionals have to adopt.
They have to adapt.
They have to adapt. Great, good. Thank you so much, Noaman Sahab. So my next question is from Professor Dr. Tahir. Please. Sir, what do you think that the large tertiary care institution like NICVD are playing to promote RPM and to mainstreaming it?
Thank you. Actually, NICVD, as it is as a single center before 2015, was catering the patients of the Karachi, not whole of the Sindh. After 2015, we developed this satellite centers, and almost every 90 minutes we have a hospital with acute care. So almost 10 hospitals are there throughout the Sindh, and we are dealing with acute MI, with care of the pediatric patient that include diagnostic and therapeutics and surgeries, and then electrophysiology, and then cardiac surgery. All these are gradually, slowly and gradually are being done. In Karachi, we, as you know, it's a huge population in Karachi, long distances. We developed the concept of chest pain unit and bridges. We have a container with the facility of acute cardiac care, and the patients are being shifted. Almost 20 chest pain units are there in Karachi. Now, when we started this chest pain units, later on we developed this system of remote diagnostics, rather the patient at the chest pain unit was diagnosed, and whole of the data of patients was transmitted to NICVD. And the patient, when he moved from, say, from a steel mill area, before that we have the data of all of the data regarding the patient, and we just ask the driver of the ambulance to take the patient to straight away to the cath lab. We don't take the patient to the ER, so we just wastage of time. That's why we ask them to come to the cath lab. With this data of patients coming from the 20 chest pain units, we have gained a lot of things. Later on, with this approach, we contacted our satellite centers also. There also we, most of the time, if we have something that is complex, that is not to be dealt from there, so we discuss them, we have meetings, and then we diagnostics and other things are we see from the remote areas, and then we shift the patient, or the patient, for patient care, we shift the consultant to that area. This usage of digital technology is highly appreciated. If you can see that in a pediatric population, the whole of the Sindh and even part of the Punjab and Balochistan is covered. The patients in the remote areas are being seen by a doctor and a nurse, and the whole of the care of the patient is being transmitted on video call to the center, and from there further the consultants are tapped and they diagnose the patient. We are in very much collaboration with the pediatric people. So when the patients come to their area and someone is having shortness of breath or otherwise, our consultant diagnose them for congenital heart or structural heart disease. So there is a very good scope of this digital phenomena in future. For that, I think in our type of a country and public hospital with lack of funds, we have to go slow and gradually, but make sure that the things are strong enough to cater for the need of the poor population.
Great contribution, sir, and we can truly understand how much efforts it would have taken for you and your team to establish such a great workflows for the enabling such digital health enabled ecosystem. So my next question is from Mr. Asadullah Khan, Executive Director, Riphah International University. Sir, what changes do you believe that are required in our academia or education system to make our medical students ready for the upcoming changes or transformation, like we are talking about AI, digital health, data sciences? But I think as a medical student, they also need to empowered, and they also need to be upgraded to a next level to adopt those technologies that are waiting for them.
So Bismillahirrahmanirrahim. First of all, it was a pleasure listening to all of you here, and very exciting discussion since morning, the first session as well as this session. Second, that there is I think there was a continuous discussion on is it going to replace or not replace. And I think the consensus has been, and I think that's the way to go, is that the technology is there. It's not going to go away. And it's going to make impact on us. And now it's up to us as leaders and as people who are decision makers to really make sure that the technology is being utilized at the beneficial level. And of course, hospitals are not going to be closed. They will be augmented. Doctors will not be out of job. They will be using AI and technology tools, and that's how they're going to increase their impact on the lives. The profound impact that they already have is going to be more impactful. And as Sara was saying, Naveed was saying that we have a lot of population out of cities, and we need to have these technologies to ensure that we reach out to them, and they are provided with the care that they need and they deserve. One thing is that, as you said, that we need to, as universities, we need to change our curricula and ensure that our students are ready for that. I think that is already being done. And like, for example, in Riphah, we have patient safety as part of our curriculum since long. We have lifestyle medicine as part of our curriculum for the last 5 years. We have AI and technology-based understanding of various courses and certificates embedded into the curriculum as micro-credentials on AI and technology in healthcare in our curriculum. So I think that's something that's already being done. What is required more is that we are in our hospitals, when we adapt these things, and when the doctors, they go into the training and they see how these devices, they make an impact on the flows and the impact on the way the care is being delivered. That's what I think is still lacking. So our students, they do understand the theoretical part of it, the technical part of it, but the implication of how the systems are going to be modified, that's one of the areas there that we need. So probably the hospitals, they need to maybe more aggressive in adapting these things. And when Noaman was saying about adapting, I think that includes indigenization of these technologies. Just something copy pasted here, which is probably he was talking about adoption, is not going to be enough. But how it's going to be impacted in our workflows, in our systems, it has to be very Pakistani, and that's what we, as we grow and learn, without being fearful and without being scary of these things, I think that's going to be the most impact, and that's where leadership comes in. But I think I would also like to point out that in healthcare, as in everything else, that the technicians and the technical workforce, they also play a lot of role. And I think that's where their training and their level of understanding in these technologies is very important. And I think that's something is very important, that we start training our technical teams, our radiographers, our pulmonology techs, our ventilator techs. All these, now these things are so pervasive, and they are so they can add so much value in all these areas. Unfortunately, we don't give enough importance to our tech teams in our hospitals, and when new things come up, we only talk about or think about the professors and the assistant professors. I think that's something which is stopping the wide-scale adoption of these new technologies. So I believe when when we talk about all this, we also have to really talk about the cost. And as Naveed was saying, these large hospitals, like we have, we run a federal government hospital for the last 20 years, and we know, these hospitals are bursting to seams with patients, and it's very difficult. So these technologies are going to help us, but the cost is very important for such hospitals. So we have to ensure that, although maybe we are not at the level of technology that we are going to probably start manufacturing the transducers and the sensors. The engineers sitting here would bet, but we can actually make the devices here. So we may start importing the devices and build the circuitry and the software here, and then the overall system and the solution should be built here. And I know our engineers and our software programmers and our telecom engineers and our electrical and biomedical engineers, they can do that. And investment must come in from the entrepreneurs as well. As this ecosystem builds and these hospitals, they start developing these technologies, adapting these technologies, then the investment should also come in. And I think one of the things which Sara was saying, that the standards that we are talking about, they are not there. And these standards will help in even investment to come in. If we know what's going to come in, and if we have some consortium of hospitals and the healthcare professionals, and identifying at least the initially, I know that things are changing very fast. It's difficult to really pinpoint and control these things, but still we need to set up directions so that the adaptation is there, and then the investments can come in, which will bring the cost again down. As much of manufacturing can be done here. I think that these are the areas where universities, hospital, healthcare professionals, and the regulators, we need to sit down together and set up some standards and some direction to ensure that we adapt it and we indigenize it, and we can actually increase the level of care and the service to our other Pakistani people. Thank you.
Sir, I truly agree with your opinion that it's a holistic upgradation that is required to Pakistan, and the effort should come from all sides, from entrepreneurs, from academia, from government, and from everyone. And we can only wish that government start taking interest in such in important topics and play a crucial role in developing policies, frameworks, and make things more smoother for the entrepreneurs and the medical professionals. Dr. Sara, my next question.
So, Bilal, can I just add one more thing to it, just from my own experience? So when we were developing, world's smallest implantable cardiovascular device or pacemaker, we worked really closely with the universities. You have to work closely with universities, researchers, because you're changing how the care is going to be provided to a patient. And then you're building new technologies to make it happen. There's always close collaboration between a company and a research institution.
Yes.
So academia plays a huge role in developing ideas. And I think if there's a close collaboration between academia and local companies, that will, I think, certainly can help a lot.
Yeah, definitely, it would. So, Dr. Sara, coming back to you. So, I guess to say Kahani, it's been like a decade now operating in telehealth.
Two less than a decade.
Two less than a decade, almost a decade. Okay, so what do you think? What truly need to be done to make telehealth truly inclusive at healthcare organizations level? I still see that from the like Dr. Zaheer, he is working in the same domain from past 20-30 years. Dr. Suhail is working from more than a decade. I think probably like sir from 20 years. So these people are working so long on the telehealth, and still we see there is a lot of gap. Still adoption rate is so low. So what do you think need to be done to make it truly inclusive?
I think the reason why you and me have been able to create InstaCare and Sehat Kahani is first and foremost because people like Dr. Zaheer and Dr. Suhail started talking about it 20 years ago. So I think it is because of them that they were here. I think that digital health is already extremely inclusive because any telehealth platform, any AI-enabled technology, you can ramp it under so many names, but let's just call them digital health solutions for simplicity. So any digital health solution, what does it do? It removes the barrier of accessibility. So if you're taking a consultation from a rural area or an urban area or a third-tier city to a first-tier city, you're talking to the same doctor using the same technology. So it removes the barrier of accessibility, of access. That is unfortunately a reality for a lot of patients of our country. Patients who reside in rural areas today, majority of them have never seen a doctor in their lifetime. And that's what happens when we create these clinics, when we have this app launched in low-income areas, we actually have patients who are talking to a real doctor for the very, very first time. And that is a reality for a lot of patients. It removes the barrier of affordability because when you have a digital health solution, when you are removing the barrier of geography or logistics, it does make the cost cheaper as compared to a physical consultation. And everywhere in the world, it makes it cheaper. So it removes the barrier of affordability. It also removes a lot of barrier of social norms that exist. The doctor-patient relationship in Pakistan is unfortunately very uneven. The doctor has a lot of power over patients. It is not a neutral relationship, but when you're talking to a screen, and that's why people, especially young people, love talking to ChatGPT, particularly for mental health issues, because it creates a conversation of equality between you and the screen. And that happens on telemedicine as well. So it is extremely inclusive. It is the way by which healthcare is going to be provided maybe 10 years from now. I think organizations like us have created a dent in changing health behaviors, converting a lot of patients who were previously going to quacks and midwives or unqualified professionals and bringing them to an actual doctor. However, collectively, I think all digital health solutions in Pakistan have touched maybe 50, 60 million patients.
Of course, yeah.
Maximum. In a country of, it's all the perspective of how big the population of the country is. Now, there is a huge, huge gap in how many companies are growing, and that will bring to my new point. You give InstaCare and Sehat Kahani collectively $50-60 million in funding, and then you ask me the question why digital health technology is not inclusive. You can't ask me this question when collectively the whole sector has raised around $40 million in funding. It doesn't work like that. So organizations, when organizations grow, they touch more patients change behaviors, those behaviors will come in their families, and that's when changes happen. It's the same way it has happened in countries like US, all the way to Indonesia, to Thailand, to Bangladesh, to India, where there were 60, 70 companies who touched 100 million, 200 million patients, and that's when the change starts happening. It's all a game of numbers. Like maybe Aman touches a couple of million, 100 million patients, and a smaller hospital does smaller million patients. So it's the same example. So to answer your question, the gap is scale.
Yeah.
Once one company or two companies reach that scale in Pakistan, and hopefully, inshallah, we will see it within our lifetime, we will see if change in behavior happens. But I've seen it on my platform. People who come and talk to a telehealth doctor one time, my data tells me they come back 8 times in a year. I don't go to a physical doctor 8 times in a year. I will never go to a physical doctor 8 times in a year. Another thing that hinders scale of telehealth in Pakistan is the patients are accepting it because they need doctors, but the doctors are not accepting that they need help also.
Yeah.
That they need technology to grow, to work faster. There is a hindrance from the medical fraternity and community to adapt to technology. Just like when we go to a midwife in a community, she doesn't want to connect to a doctor because she's the doctor in the community. Mm-hmm. So just like when we go to bigger doctors in bigger cities, they don't want to connect to their patients in telehealth because they think somehow the experience can only be met when the patient comes to them physically. Yeah. So as we are changing behavior in patients, we also need to change behavior in doctors, making them understand that maybe ChatGPT will stay for the next 50 years, we won't.
Yeah.
So we need to change with it, and with all the technologies coming with it, to be able to meet the patient's need. The third thing I think that hinders, again, is what is actually the level of care that's being provided. So right now you see a lot of technologies working in different sectors. I think one thing that is needed is also consolidation of all these different technologies out there under single umbrellas. Because as we create mushroom growth, it will never grow. So I think in the next 5 to 10 years, if inshallah, funding situation or the whole macroeconomic situation improves, you'll see a lot of acquisitions and mergers in organizations. And then you will see these bigger companies come up that will be able to reach scale. across the country. Yeah.
Yeah, thank you so much, Dr. Sara. You have highlighted some points that I think every digital health entrepreneur is currently facing, and we wish all those challenges get solved soon.
Okay, मैं और आपकी और अपनी दिल की बात कर रही हूँ इस पैनल में.
मैं feel कर सकता हूँ. ठीक है. Dr. Suhail, I always, your personality is very inspiring. The way you are leading digital health. You are a teacher, you are a software engineer, you are a cardiac surgeon also, orthopedic surgeon also. It's like you have a very diverse background. You understand technology very well, better than even us. So my question is that, and you have the experience of both UK-based healthcare system, which we call NHS, and Pakistan healthcare system. What lessons we need to learn from NHS that needs to be adopted here to enable digital health the way NHS England has done?
I think to include the patient in the conversation is very important. I like when Sara said in the first comment that patient experience is very important. If you go to a shop and you find that nobody was paying attention to you, you would rather go to another shop next time where somebody pays attention to you. And I give you one little example which turned, I published my few papers. One of the papers was about 1800 teleconsultations versus 700 physical consultations after COVID in England, talking about NHS. And the experience of the patient coming online actually turned out to be better. And how? I just show you what I did, few things, which you can all try. When you talk to the patient on telemedicine system, don't look on the screen. Don't look on the screen. Look in the camera, because the patient gets the feel someone is talking to me, not at me. Okay, look in the camera. Second thing is, don't do too many things when you talk. If you know the software, you don't need to learn it when the patient is there with you. Learn it beforehand. And the third thing we do in my software, I've sold 2 telemedicine companies. Every software had one thing in common, that the doctor had to learn the patient side of the software. That is very important, that if patient is stuck, doctor can say, can you look at the top left? There's a blue button there. Below that blue button, there's a small bar. Click on that, you will see my sound. You will see me and hear me. That kind of knowledge you need on both sides of the screen. And the third thing, in Saudi Arabia, I deployed software, and I placed spacebar bringing a green filter. When the lady's niqab wheel drops, press the space bar immediately, it will haze out the screen. So that's a local cultural adaptation, which means that you have to adapt it for Pakistan, in Pakistan for Karachi, in Karachi for Kurangi. That kind of scaling down you must do when you try and develop a software. It's all in coding. There's no hardware required. Same screen, same monitor, same laptop. The trick lies in how you present it in the code. So all of these things put together, InstaCare and Sehat, Kahani, I've seen their journeys, and I'm actually proudly mention them. Recently, by the way, I've been taken as the editor-in-chief of TeleHealth Today, New York. That's the news I heard this morning. So I will bring not only UK perspective in the telehealth, one of the leading telehealth journals in America. I will bring Pakistan into that. And I want InstaCare and Sehat Kahani to bring the data, because ChatGPT is biased on European American data. You guys are not publishing enough. And what you're publishing is sometimes has authenticity issues. Let me be honest, and let me say it as a Pakistani here, that we have to be authentic. Put ChatGPT at the last stage. Okay, what do you think my paper is like? But before that, it's you. So answering Bilal, your question, I think the challenges will remain, they will grow. But we need to grow out. Yeah. We need to understand patient has to be in the consultation. Of course. If patient is not there, you haven't won the patient. Yeah. Thank you.
Thank you so much, Dr. Suhail. Dr. Fariha, what do you think that globally RPM and the global healthcare practices are changing? Like they are focusing on they are changing from reactive prevention to predictive prevention. So they don't just consider this like you detect stress in a patient 72 hours before a cardiac arrest, and you just save that patient's life. Do you think hospitals in Pakistan are also on the same trend, or are we too far from adopting such technologies? No, Mike, please.
Thank you so very much. And the conversations that we've been having always come down to the challenges, right? And Pakistani physicians in Pakistani healthcare. The first thing that I need to mention, there are two phases of this question. One is screening and predicting. The other is using the remote monitoring or telehealth for predicting cardiovascular care. Cardiovascular issues, and the second is management and continuity of care and reducing the burden of tertiary care hospitals, because there's so much that we see, right? So if we say reducing the burden of tertiary care hospital by integrating telehealth and remote monitoring, this is the first step that we've already taken. 20 years ago, 30 years ago, Dr. Zakiuddin and Dr. Chughtai, they've started rolling the wheel. Sehat, Kahani, InstaHealth, they've picked up, right? But this needs to be integrated into the hospital with already developed workflows so that we can bring all of them in unity. And we do not duplicate or replicate things. And also, the quality of data that the physician sitting in the hospital needs to make decision also depends on the quality of the data that we are receiving. The people who are looking at the data and interpreting and relaying it to the physician needs to be completely made sure that they are unbiased and they have a quality to it. The second part of using the digital health and remote monitoring is predicting, screening, and my personal experience with predicting and screening comes to the remote monitoring of ECGs and for arrhythmia detection, which is atrial fibrillation, and we at Aman Ventures, we have been using this monitoring device to predict, especially when I talk about arrhythmia, we talk about atrial fibrillation, and atrial fibrillation in the end will cause stroke. To prevent stroke is to detect atrial fibrillation, and to detect atrial fibrillation, we need to predict when it's going to happen. And remote monitoring devices, not just the digital watches and other gadgets. There are devices that are actually using AI model to predict those arrhythmias. So this is another step towards remote monitoring, to predict, prevent, screen, and then treat before it actually happens. So we are getting there. This is the first step, and we've already taken the first step.
Yeah, congratulations, and I think more examples need to be set, so more innovation can happen in this ecosystem. Mr. Naveed, my next question is from you. That, sir, if we see the region, if we see China, Africa, India, we will find a lot of startups working on medical devices. But in Pakistan, I know a few startups which are working on those medical devices thing, but we can't find huge success stories out of them. So if someone wants to start a medical devices startup today, so what support experienced people like you can offer them?
Well, thank you for asking that question. I think, let me take a step back before I answer the question you really asked. I think there needs to be, number one, understanding that technology, especially in healthcare, needs physician involvement. Okay. So a technology just cannot be developed by technologists like me. I will come up with solutions which may not necessarily be applicable in the situation and how a physician wants to use it. There needs to be a close collaboration between a technologist and the medical community to make it happen. I think that's the baseline. Now kind of going back and asking the question that you asked about how, I can help or somebody from outside can help. I think there is, of course, mentorship that can be provided. The funding can also be provided for some of those ideas. But kind of going back to taking a look at, I was reading an article yesterday. I'm just going to give you an example. I was reading an article yesterday. I don't know how it came to me, but it came to me like, it was from the finance minister of Pakistan. He said that, I think, population growth and climate change is a barrier for Pakistan to get to a 3 trillion technology. And I was kind of surprised by that. Because I think healthcare also needs to be part of that. Because if your population is not healthy, you are not going to get to a point where your economy is going to grow. Yeah. A lot of technology development that I've been involved in over the last 25 years or so has had huge input from the governments that they want to go in a certain direction. Even working in the US, working in industries which you see right now, for example, autonomous vehicles, satellites, the technology that is the baseline for AI. The government funded that technology. There was a way that ideas were developed. Government wanted to go in that direction. The ecosystem was created so that we could move in that direction. So when I hear at the government level that healthcare is not part of anybody's vision, I don't see how the change is going to come. Correct? So when that space is created, maybe there are venture capitalists or people who really want to go invest in that area are available and want us to move in that direction. But I think there needs to be a cohesive strategy that is led by the power to be here, that they want to go in that direction. So that way we know that is the direction we want to go. So simplifying the answer, kind of going back to what you simply asked me, there are a lot of experts sitting here, and they certainly can help a lot from the perspective of at least giving the baseline for what should happen. As far as the investment is concerned, that certainly can come from policies. If there are policies that a certain direction needs to be taken in healthcare, the investment will come. Sehat, Kahani, InstaCare, you guys have been working in this area, and as previously also mentioned, if there is a demand, the money will come, the companies will grow, people will see benefit of moving in that direction, and there will be an ecosystem created to get us there. But without that, there will be small things that will continue to happen, correct? And so kind of going back to what I was saying initially, there needs to be a concerted effort to get us there. But giving some kind of getting back to what Dr. Asadullah Khan was saying, universities are also incubators where ideas come out of. Utilize university education, utilize expertise that is getting developed there, and then bring it out and support it. Nourish the idea. Allow that to grow. And then that certainly can also create an ecosystem where things can come out of. Hopefully that answers
definitely.
that question.
Thank you so much, sir. Mr. Noaman, my next question is from you. May I have the mic, please? So you are a robotic expert as well. So please share your insights with us that where is Pakistan at the moment in terms of robots and robotic sciences in the healthcare space?
Well, it's preliminary to say. It is an evolving technology, and it's very early to say where Pakistan stands, because the cost itself is a key factor, and the expertise of the surgeon who are specialized in this robotic surgery. But there are few instances where some private hospitals have taken major drastic innovative measures. They have installed the surgical robot like in Lahore and in few places in North region, and it has immensely created wonders that I have come across discussing with them, that the surgeon is commanding the robot to perform surgery with the assistance of paramedical staff. There is no direct transmission. The consultant or the surgeon doesn't need to scrub. Even in remote areas where there is a lack of movement or some security measures, a surgeon abroad can perform surgeries via telesurgery. That also have happened in Pakistan recently, and in next month will be hopefully doing so. in Lahore and Islamabad. So what I have come across with the feedback of the surgeons doing robotic surgery is that they have seen during the procedure those minute details that they had to cut to see the other side of it. Secondly, it is basically a minimal invasive surgery. Maximum the dia needs to be cut is of starting from 5 mm to 11 mm max. It is far more less fatigueness to the surgeon, smooth, less hospital stay, fast recovery, less antibiotic, less painful due to the lesser minimally cuts. So it's in Pakistan is an developing stage, but companies who have proposed the installation of these SRs have proposed plans for pay-per case as well for the deferred payment, curtailing the cost burden directly or indirectly to the hospitals as well as on to the patients. So there are different methods of placement and direct purchasing through different financial methods.
Right. So thank you so much, Noaman sahab. So I would like to thank all my panelists for being here. It was truly an honor for me to host you all. And I hope everyone learned from the diverse questions. And this concludes our today's session. Thank you so much.